All right.
Let's see. Is it good?
It is. Go into full screen mode and you're perfect.
Yep.
Perfect.
Okay, so you can see the slide.
Yes.
Can everyone see the slide?
Yes, you're good.
Okay, okay. Because I can't see the other window. I can see only the slide window. I don't know how to get that back.
As the speaker sharing your screen, that
Oh.
it is what it is. Sorry.
Okay, all right. All right. So can we start?
Yes, please do.
All right. Thank you, Christy, for inviting me to this talk. I'm a new physician in this area. I have been here for about a year. I moved from Florida, where I had been working with the Cleveland Clinic system in Naples. I was a chief endocrinologist for about 10 years. And then before that, I was with the Mayo Clinic in Minnesota. And before that, I started my life here in Stanford, where I did some research with the reproductive endocrinology department. And then eventually I made my way to the Middle East, the Midwest. And then I started with my career with the Mayo Clinic, and then became a full-time consultant with the Cleveland Clinic. Well, Cleveland Clinic decided to close their operations in the town where I was in, and then they wanted me to either move back to Cleveland or go to the Middle East somewhere, which I did not want to. So I was looking for other opportunities and found Ampla. So that's why I'm here. So I was interested in hormone replacement therapies from a long time. And having had the opportunity to work in reproductive endocrinology, I did a fellowship in reproductive endocrinology in the University of Geneva in Switzerland a long time back. And I still retain my interest there, even though I did not want to go into OBGYN and become a reproductive endocrinologist. But I wanted to stay in general endocrinology to keep my outlook broad. So I do have retained that interest. So when I came to this part of the world, I found that there's a significant population of transgenders here who are requesting help. So, which is why I went into this one. So I do have my share of transgender patients now here, having been here for about a year. And that is the subject which I want to start with. And again, I thank Christy and Butte County Medical Center Society, as well as Enloe Health for having me here. Transgenders account for about 0.5% of adults in today's world, and approximately about 3% are in youth. For the physical and mental and psychological well-being of the patient, it's important for us to coordinate these therapies because otherwise it is often leading to significant amount of psychological, mental and physical disharmony for the patient. Unless you've been in their shoes, you're not going to understand what many of these folks go through. Feminization therapies and masculinization therapies exist several different ways and forms. Some are surgical, some are medical, many of them are psychological and social rehabilitation parts also. So necessitates for me to say that this is going to be a multi-specialty, multidisciplinary approach with the help of clinical psychologists and psychiatrists and primary care physicians and whatnot. So there seems to be a need for such an evolving specialty, especially with more and more of adolescents and adults realizing that they may have what we call as gender dysphoria. And when they are openly discussing this with their primary care physicians or their psychologists or psychiatrists or at work, many of us may be around to help. And it also needs a lot of training so as to realize the pitfalls, the troubles that we go through, because this is kind of a lifelong commitment. So unless we understand where we come from and where the patient comes from, we cannot do a good job of rehabilitating them, helping them cope with their stress, as well as helping them cope with change in their bodies. So treatment should be individualized, and side effects have to be explained in detail, because these people, most of them which I see are adolescents or young adults, and then this spans a lifetime. So naturally, all these medications, when you're physiologically and phenotypically a male or a female, and you're trying to divert that body into being phenotypically the other sex, then naturally that body will have to respond in some way or form. And you will begin to see that as side effects to medications, as potentially life-threatening side effects, disorders, maladjustments, things like that. So we have to be careful in what we are advising patients and what we are looking for in each follow-up visits. So we'll start with female to male transgender. So because I do see a significant proportion of this, as well as to male to female, which is, I would say, about in a 55 to 45 ratio. More female to male transgenders and less male to female transgenders. I don't know what your experience has been, but that is a sampling that I've had in the short period of time that I was here. In the rest of the world, the rest of the country also, I think it is pretty much holds good, that ratio. So starting with female to male transgender, again, let me say right now that if you have any burning questions in between, feel free to stop me and I can stop and discuss, and then we can move on, okay? So you can use the chat feature also, or just straight away interrupt, no problems. In female to male transgender, again, we are focusing on medical management from an endocrinology standpoint or from a primary care physician standpoint. The surgical part and surgical aspects, I'll dwell briefly, but I think you have a surgeon here who can explain the use of different therapies. So the use of testosterone injections or in the form of cream or gel or tablets, submucous or sublingual tablets to help with masculinization, that has been around for a long period of time, and we are pretty much aware of the benefits, risks, and complications. The usual benefits are it deepens your voice, facial and androgenic hair distribution will become demonstrable in as little as 2 or 3 weeks, and it increases muscle mass certainly, and suspends menstrual cycles, especially if it is a menstruating woman. Can proceed, or it can be done in conjunction with gender reassignment surgeries. And typically, this is one of the questionnaire that I go through with patients when I see them for the first time. I ask them, have you thought about gender reassignment surgeries? And if so, what kind of commitment you are? It kind of gets me the feel of how deep the patient has gone into in terms of gender reassignment, or at least socially adjusting with that new social status. I've also picked up, there was a 15-year-old girl who came to see me with her dad and who wanted to be a boy. She had always fancied herself as a boy, always enjoyed playing with cars and with masculine type of toys, and also associated herself with boys in school. Always wore boys' clothes and cut her hair short and all that. She looked very much like a boy, but when the body begins to change in puberty and all those things, that's when she was more aware of this, caused a significant amount of psychological stress, was teased and bullied in school, things like that. So after having undergone so much of this psychological, mental stress, she mentioned this to her parents, who had kind of a feeling that this is possibly what she's suffering from, and then they took her to the therapist and then subsequently to the psychiatrist. So I made sure that they had gone through all those, and usually they say at least about a year worth of therapy or going to the psychiatrist is usually very helpful in formulating their thought processes. But in this case, what I found was that after discussing all of these things with this patient and her father, and especially because her body had not undergone maturity yet, and I said that if we resort to switching over to one form of hormonal therapy, it might close off her epiphysis a little faster. She may not attain her projected bone growth or height, vertical height, and that maybe make her at a disadvantage of her confidence levels, things like that. So with the net result that the patient and her father decided to think about it and come back to me later, and then which they did. In about 2 months' time, they came back and told us that the girl was a little bit more confident this time. Said that maybe I want to think about it. So maybe I want to finish my 18th year and then possibly revisit this issue. For now, I'll continue as it is, and I understand the pros and cons of all of these things. So it took about an hour of counseling from my side, and then giving her access to several websites and understanding about the risks of using testosterone or estrogen in the male. So in conjunction with all of these discussions, we can provide all the information and also gender reassignment surgeries. I've several patients who've had gender reassignment surgeries. Some of them have been very successful. Some of them have not been so successful. It involves a significant amount of cost. So it may not be covered by your insurances and all those. So all those things become very important to be discussing with patients. And there are many insurances who are still toying with these ideas in their infancy. So it's not a very easy process to get insurances to accept or to cover for these surgeries also. The metabolic effects is what I deal with. So I explain to them that giving you hormonal treatment is not a piece of cake, and it's not just simple as writing a prescription and you start the medication or the treatment and then everything will be hunky-dory and you'll be overnight changing into a man or a woman, whichever way you want. So there are a significant amount of risks, and it's every single visit, every single stage we have to revisit. When you are converting from pubertal stage to a young adult, and from a young adult to middle-aged adult, and middle-aged to elderly. At every stage, there can be a significant amount of stress, and the stress in one way or form on the body, whether it's psychological, physical, those kind of things. Initially they will have a lot of acne. That may be a problem. Subsequently, they may have hair loss from the vertex of the skull, and they may or may not like the idea of the excess hair growth. Rest of the body, everybody wants to look good on the beach, and that may be an issue. So all those things. So stress and concerns come in variable sizes and forms, and we'll have to deal with it. So one good thing about female to male transgender is that the data, even though it is very small and limited at this stage, the cardiovascular risk remains unchanged. Means that if your Framingham score or if your risk for getting an MI or a DVT is so much as a woman, if you convert yourself into a man and use testosterone, that risk really doesn't change for a woman. But if you coming from a family with a significant amount of DVT in your family, cancer risk, and all those, and early heart attacks and strokes, and of course that risk will still be there. So in that sense, it behooves us to understand that the CV risk is not changed if you're a female to male transgender, but male to female transgender, we are not so sure. The data is still very hazy at this point. So metabolic changes with testosterone, we know that it lowers HDL. It can raise triglycerides. It can stimulate your bone marrow and result in a secondary polycythemia, which is very, very common. What do we do about it? I've seen many patients whom I've inherited from other practices where hemoglobin is 18 grams or 18.5 grams and still going strong, no problems, no side effects, nothing. So, well, no advice either. So, but this is risky. So we have to understand that the viscosity of the blood changes significantly when you go from a hemoglobin of 16 grams or 16.5 to 17 grams and upwards. So my cutoff is 17 grams. If the patient crosses 17 grams, I insist that the patient donates a pint of blood or undergoes phlebotomy of 1 unit of blood, whole blood. If the patient is a plasma donor, especially significant because you need to remove cells, not plasma, because the viscosity of the blood is directly related to the cell content and the secondary polycythemia and the increased red blood cell burden can be significant on the patient's circulation. I frequently ask them, do you get headaches? Do you get visual phenomena? Do you get itchiness of your back? These are all sluggishness of capillary flow. And if there is significant blood clotting in one of your sinus veins inside your brain, that's a significant life-threatening condition. So we need to avoid all these things. Of course, we all know about DVTs and the risk for pulmonary embolism. It'll be a lot less risky if you predict this ahead of time and then keep on checking their CBCs and asking them to be hydrated all the time, put them on an antiplatelet agent, and possibly I frequently give them fish oil capsules. Omega-3s are very beneficial to reduce incidence of fatty liver, as well as to reduce triglycerides and boost HDL production. So those are all helpful measures or adjunctive therapy to prevent complications. So again, you have it in your sites, and you let the patient know that this is a known side effect, and we have to keep advice so that each time the patient comes in, the patient too should be asking, what is my hemoglobin? What is my hematocrit? So it can produce DVT, cerebral venous thrombosis, and circulatory disturbances. We talked about periodic phlebotomies. I usually recommend using like 2 phlebotomies a year, like every 6 months or so, if the hemoglobin persistently is over 17 grams. And use of omega-3 oils and antiplatelet therapies. And we'll adjust the dose of testosterone based on levels. Now, word about levels. We frequently refer to a male range of levels, which is between, say, 240 to 800 to 1,000, depending on the lab you look. So in male, because you've got testicles, the testicles secrete testosterone every 2 hours. So you get a pulse. So there are about 12 pulses that happen in the 24-hour period. We start from 200, we go to 1,200 or 1,000, come back down to 200 again. So if the sampling time can determine the amount of testosterone at a given point of time. So if you average it out and you want to have like 500 all the time, you may not get that. And that is not the goal for a woman trying to convert to a man. For secondary sexual characteristics, for muscle function and deepening of your voice and your facial hair, body hair, things like that, you probably need only about, say, 200 or 250. And you can stop there. There's no point in trying to attain like 500 or that similar to man's levels to get all these things and to sustain these, because we know that if you have polycystic ovarian syndrome and you're a woman, if your testosterone level rises up to 80 or maybe 90, you begin to show facial hair, you begin to lose your menstrual cycles, you begin to have a male pattern of baldness, all of those things, and acne on the face. So you can imagine what it'll do if the testosterone level jumps up, say, from 100 to 200. So if you're looking for phenotype, that's all what you want to do. So have facial hair, deepen your voice, muscle mass. That's about it. What else are you planning to do? What else are you going to get if you raise your level from 100 to 500? So I generally dissuade patients to say, oh, this mine is only 200, or mine is only 100. I have friends who have got 500 or 1,000. There's no added benefit. So again, the metabolic effects of testosterone can be seen by titration as early as 6 months, and more than 3 months to 6 months. More than that, even if you raise your dose, you're not going to gain anything better. You're going to court more side effects. Again, the cost analysis, we need to discuss about that with the patient, whether it's worth it at the end of the day, having undergone so much of expensive surgery. So I tell patients, even if you're happy with the way you're looking, phenotypically you're a male or phenotypically you're a female, And even though you have got the wrong organs inside there, it may help if you remove the testicles or the ovaries, or you override it with hormones. As long as you're getting the materialistic benefit that you're looking for, you have to really weigh in the cost and the complication rates of surgeries also, because they are scarring. Male to female transgender, using of estrogens and anti-androgens to produce feminization and female type of fat distribution. These are our goals. We can use estrogen in the form of patches. That's what I prefer. Tablets and injections used to be in vogue before. Even nowadays, I can see practitioners give out that. I tell patients that, trying to avoid the first pass metabolism in the liver and trying to get the similar type of blood levels in the blood is probably better than having to court, fatty liver, as well as fatty tumors, as well as hematogenous tumors inside the liver. It's probably not going to be helpful, not going to be a good idea, and also it causes a significant amount of cholestasis and getting gallstones and other problems. You may be trading one problem for another all the time. So I tell patients using estrogen in the form of creams or gels or patches. Patches are very convenient to use. You can change the location as you choose. You can use frequency. It could be like once a week or once every 2 days or 3 days. And we use a dose, typically 0.1 milligram per day or 0.2 milligrams, up to 0.2 milligrams a day to get the desired benefits. Anti-androgens can be used concurrently. Frequently I use spironolactone. You can use progesterone, hydroxyprogesterone, things like that as an anti-androgen also. But again, you have to weigh the risks versus the benefits. Some of them may be too edema forming, too much of endogenous, temperature rise, hot flashes, triggering, things like that. So, and also using spironolactone, you have to worry about your potassium levels and frequently get potassium levels checked. We use aromatase inhibitors, things like that also. It can be concurrent with orchidectomy or gender reassignment surgeries. Orchidectomy is simple. It is once the patient is thin enough. It may be a good way of blocking the endogenous testosterone, even though you can block the FSH and LH, which doesn't send any more signals to the testosterone. Your pulsatile testosterone secretion stops, and then the estrogen will take over. So even though you can use a lot of estrogens typically to get female type of breast tissue, you probably may need to have breast surgery, breast augmentation, things like that, which is relatively very safe, and you can get good cosmetic results with the right surgeons. Estrogen creams or patches, tablets, injections, anti-androgen tablets, and aromatase inhibitors we talked about. And again, seriously, you have to have a significant amount of time discussing metabolic effects with the patient, so the patient is put at ease regarding what each one entails. It raises triglycerides, can cause fatty liver, we discussed that, risk for DVT, and cerebrovenous thrombosis, use of GnRH analogs for pubertal suspension. That's one thing which we use in younger individuals, especially pubertal stage. I tend to not to use this one because of growth issues which it can produce. For that reason, I usually defer these decisions to pediatric endocrinologists once they decide that, okay, the patient's growth plates have fused, have attained target height and everything. Options for fertility preservation to be discussed always with any patient, either freezing away eggs or harvesting sperm, and cryopreservations techniques should be discussed. Lack of evidence for any of these treatments can complicate the issues because the database is very small and limited. Most of our experience is from hypogonadal men or women, or cryptorchidism, or ambiguous genitalia cases, which could be genetically determined, and we have used hormone replacement to cover that. So that is the only database that we have, and that is not foolproof by any chance. Again, these medications have to be used lifelong, so you have to weigh every risk with the patient. And morbidity and cardiovascular risk variation with hormonal substitutions unchanged in transgender men. We talked about that. Unknown women. Again, benefits, mental health and depression, etc., are found to improve significantly after such treatment. Long-term outcomes are unknown. Cardiovascular disease is the leading cause of death, and frequently gender-altering hormonal treatment is initiated in youth, continues in the elderly, so high doses. Sometimes some people use to get desired appearance, or they think that they can improve it with using higher doses, which is not true. Unchanged cardiovascular risk of use in low dosage, according to levels in serum in transgender men that we discussed. Again, regulation is through World Professional Association of Transgender Health, WPATH, and Endocrine Society guidelines. And it's based on, again, clinical experience only. Long-term data is not available. We extrapolate treatment of hypogonadal men and postmenopausal women. And that's the biggest database that we have regarding metabolic benefits. It's recommended generally for all transgenders to live in 12 months socially as the other gender as a test before starting treatment, but in many cases it may not be practical. So we simultaneously, along with medical transition, we do the social rehabilitation also. Again, WPATH recommends initial evaluation done by professionals before hormone replacement therapy. In the Cleveland Clinic, we had a team of doctors where we had an initial visit with the psychologist, then with the psychiatrist, then we had a visit with the primary care doctor, and we have a combined appointment with the endocrinologist and everybody else. So again, we need to have an informed consent. Optimization of other medical or mental comorbidities also could be necessary, like using antidepressants. Early titration or higher doses may be effective for virilization. But again, these titration we do only for up to 6 months until we achieve the desired endpoints. 5-alpha reductase inhibitors can be used for hair loss and as anti-androgens, but again, no data exists for use in transgender patients. This is all in hypogonadal men that we've used before. Spironolactone can be an adjunct, and watch for potassium levels. That's all I have for today, and I'll stop here and open up the discussion.
If you have a question for Dr. Sunil, you can unmute yourself.
Is there a
Yes, sir.
certain age, excuse me, that you look at for starting this?
The question is there an age for starting this? Again, that's a question which has to be answered by your discussions with the parent, yourself, the referring physician, everybody. My bias is that if the body is not grown fully enough or attained complete potential growth, you're possibly asking for trouble in terms of early fusion of the epiphysis, in reducing potential heights, things like that. So that is one of the biases which I have. So typically, if I see somebody below the age of say 18 years, I usually discuss all of these things with them. And then if I get the feedback from the patient, the referring physician, the psychiatrist, psychologist, that no, I know they are all aware of all of these things, we want to go through this one, then I usually typically refer them to the pediatric endocrinologist to get their opinion about growth, and then we embark upon treatment with hormones. But as for the upper limit of age, I don't have a bias towards that. I've had patients in their 60s and 70s come to me and ask for such treatments. And as long as we explain the side effect profile, again, it all depends upon comorbidities. If they have a significant amount, somebody who has had a 5-vessel cardiac bypass and diabetes and obesity, they may not be a good candidate for getting on hormone replacement therapy at that point, because you're going to weigh the risks of having a DVT or a blood clot or an early MI, those kind of things. Does that answer your question?
Yes, thank you.
Yes, so Dr. Wright.
Yes, when you're considering the modes of medication and looking at the options of the creams or the gels on the one hand, oral tablets or capsules on the second, and thirdly, the injectable. Overall, do you have a preference for one of those approaches that gives you a more consistent and more reliable result with the lab studies, or are they all pretty much equal?
Are you talking about testosterone or estrogen?
Testosterone.
Okay. Regarding testosterone, my preference for the use of the modalities is I would lean more towards transdermal approaches like creams or gels first, because of, it does not give you a peak and a trough effect. It gives you kind of a steady state effect. So there is less potential for causing DVT and less potential of causing the other complications. Like if I'm using it in a man, there is less potential of causing prostatic enlargement and prostate cancer. Whereas with injectables, again, you have to use, invariably you'll end up using a higher dose. You'll have a peak and a trough effect, and you'll end up stimulating your bone marrow far more frequently and end up with more polycythemia, as well as waking up the prostate too early and courting disaster. So these are my biases when I use testosterone. But if I'm using testosterone for a woman, I usually use much lower doses, because we can get virilization much earlier with lower doses of testosterone. And with women, the issue of erectile dysfunction does not occur. It usually frequently improves libido significantly, so they don't complain. Whereas in a man, they want, in spite of all of these things, you may not get enough curative power for the erectile dysfunction. And for erectile dysfunction, I usually simultaneously use, some of the PDE5 inhibitors like sildenafil or vardenafil, which will be concurrently effective.
Mm-hmm. Good, thank you.
You're welcome. More questions? Did anything come through in the on the website or anything? No.
On the chat, no, but
Yeah.
that was it.
Okay, so thank you so much, and I'm waiting to hear our next speaker.
Thank you so much, Dr. Sunil. I'm really appreciative of your time. And why don't
Thank
you stop sharing your screen, and then Dr. Hashemi, do you have a screen to share?
I do.
Excellent. And then just as you're getting ready, I just wanted to note, I put it in the chat, but Dr. Sunil will also join us in August to talk about diabetes, new treatments and things, updates. And here is Dr. Sean Hashemi.
Well, hello, everyone. So we're going to do a little talk on voice feminization here. Thanks for that talk. That was very interesting. Just to start it off, I have no financial disclosures. All pictures that I have in this presentation are from either journals or the internet. They're not from my own surgeries. So who am I? Well, hi, nice to meet you all. Dr. Sean Hashemi here. I'm ENT, head and neck surgery at Enloe, and also facial plastic and reconstructive surgery. I am from the Bay Area. I was born and raised there. So I'm a little bit of a newcomer to Enloe. I've been here for about 9 months. But I'm a Northern California guy and feel a pretty natural connection to our community and patients here. I did my ENT residency at Boston University, which was a 5-year residency. And BU is a pretty unique center and very appropriate for today's talk. We did a lot of facial feminization, voice feminization surgery there. In fact, we had a fellowship there for facial plastics, which was the only really training center for that. There are some other ones that have kind of come up to speed, but it's a very high volume place. So we had a lot of experience with it. And then I did my facial plastic surgery fellowship after residency at the University of Toronto. And now I'm here. So a little outline of the talk today. We're going to talk about voice feminization. And of course, the main goal that we have for our patients is that they're identified as a female with their voice. whether that's in a coffee shop or on the phone. That's the main outcome we're looking for. Of course, one size does not fit all. Everyone needs an individual approach, which is important to take away from a surgical perspective. And that means that there's certainly a non-surgical and surgical approach to getting patients to where they want to go. So speech, it's a complex event, and it's not only related to the vocal cords. Airflow comes from the lungs, passes through the subglottis, moves past the vocal cords, and then you get oral pharyngeal resonance, which produces a unique sound. Behavior is very important, patterns, body language, the resonance, reflexes, all that stuff is very important for how voice is perceived and executed. The female voice, compared to a man, there's clear articulation, breathiness, there's dynamic frequency changes, upward intonations, and a higher fundamental frequency, which is the pitch. So you can see here the frequency is one component of it, and then there's other factors that are very important for a female voice. That takes me into talk about speech therapy, which is our main non-surgical approach to getting patients the feminine voice. The easy button there is meant to be facetious. It's not easy at all. It's a lot of hard work. It's easy for me because I don't necessarily have to do it. I get to refer them to a speech therapist, but the speech therapist and patients have to work very hard to get to where they want to go. It can be successful alone. And so on the spectrum of feminization surgeries, voice surgery is more rare when patients are looking to identify as female compared to, facial reconstruction surgeries. But, if you just think about voice actors, cartoon characters, you can do a fair amount with the voice alone and an appropriate vocal coach. Areas that are targeted are the oropharyngeal resonance in a physical manner. So changing the length of between the larynx and voice coming out from the lips, tongue movement, consonant articulation, behavior of the patient, and where they place their emphasis during their speech. There can be a meaningful change in the pitch of the voice from around 125 to 168 hertz, which isn't quite in the female range, but it puts you in that borderline area where you can be identified as female. And of course, speech therapy before surgery and after surgery is integral to outcomes. So the female voice, there is an optimal fundamental frequency. Studies have blinded observers, and a female voice will be naturally identified at about 196 to 224 hertz. Males much lower, about a full octave lower, 107 to 146 hertz. And then the borderline range of 155 to 160, where it could go either way. Fundamental frequency, there's a nice little equation for it. F naught equals 1 over 2L times the square root of T over P, T being tension and P being the mass density of the vocal cord itself. So surgery can target all three areas. You can increase the tension, which will increase the fundamental frequency. You can decrease the mass density of the cord, and that will increase the fundamental frequency. And decreasing the length of the vocal cord per that equation, you'll get an increase of F naught. Little brief review of the anatomy. At the top of the picture, you'll see the anterior portion, and then the bottom of the picture is posterior. This is a view you would get if you were intubating a patient, and the same view more or less that I have during surgery. And the left vocal cord, right vocal cord, and the trachea just distal to it. The top of the vocal cords, if you look at it and it's an A, that's an area that we refer to as the anterior commissure, and I'll use that term in the next few slides. So surgical procedures that can be done, there's cricothyroid approximation. The cricothyroid muscles are external laryngeal muscles. They are provide tension to the vocal cords. The surgery is done with an external incision, so patients do have a little scar. You basically will be suturing the left and right cricothyroid muscle together to increase the tension. Anterior commissure advancement is just as it sounds, it's also an external procedure, and you're basically advancing the actual structure of the anterior commissure forward to increase the tension of the vocal cords. Laser glottoplasty, this is addressing the mass and density of the vocal cords, and it's basically laser ablation of the cords. And Wendler glottoplasty, also called the anterior web glottoplasty, is the procedure that I perform and I'll focus on. And that picture there on the slide is a Dito laryngoscope. That's the laryngoscope that I used during surgery. Dr. Dito was an otolaryngologist from UCSF, and it's a workhorse laryngoscope that I use very frequently. The picture that you see there, that's a common setup for what we call suspension microlaryngoscopy. Suspension, the patient is essentially suspended from that laryngoscope, and the laryngoscope is fixed to a rigid surface to keep it in place. Micro, because we use a microscope, and so the surgeon can use both hands during surgery. This is creation of an iatrogenic anterior glottic web, which decreases the vocal fold length and raises the fundamental frequency, raising the pitch, making a more feminine voice. This is an intraoperative picture of the glottis. So you've got the left vocal cord, the right vocal cord, one on the left, one on the right, and that's a laser safe tube, endotracheal tube that you see in the subglottis and trachea. You would use a CO2 laser to ablate the anterior 1/3 of the vocal cord. You want to get the vibratory surface of the vocal cord and also make sure you go through full thickness into the anterior commissure. The goal here is creating a large denuded surface that is going to create a rigid scar. And then you place sutures to suture the cords together so that a mature scar can heal. I use absorbable sutures. I use a PDS suture. It lasts for several weeks to months and dissolves. Other people use Vicryl, which is similar. You know, there's a lot of different sutures that we throw in different parts of the body, especially in head, neck, and facial plastics. I will tell you that this is easily the hardest suture that I've ever thrown, but it's, of course, as with everything, gets easier with practice, but it is humbling. So this is a side-by-side picture of before and after intraoperatively, and I just wanted to point out the decrease in the airway aperture. No doubt this freaks people out in the room, notably the anesthesiologist, and even when you do it yourself, you just almost can't believe what you've done. So this is important because patients are counseled extensively preoperatively that they're going to be anxious in the recovery room as well as at home. They're going to feel like they have a tight airway. You know, as long as you've done this and you know how much to do, you won't over tighten and close the airway too much. That's never happened to me. I've never seen that, but it's of course within the realm of possibility. So post-operatively, the shortness of breath is expected, particularly in the recovery room when they wake up and they're experiencing it for the first time. Patients have an activity restriction, no strenuous activity for 3 to 4 weeks. I don't want them putting any wear and tear on their voice box. I ask them to do a strict voice restriction for 1 week. That's no talking. And then speech therapy is paramount. I see them back at 1 week and see how it's healing. I see them back at 4 weeks, make sure it looks good. And then I clear them for speech therapy to begin at about 6 weeks after the surgery. I let patients know that scar takes about 6 months to a year to heal. So it's a process. What they get after surgery is not going to be their complete voice. And they need to be patient with it. And that's a healed after picture. That's a before picture and an after picture. And you can see there is more airway now. It does look safe, but there's a fair amount of scar formed at the anterior portion of the cords. the way I kind of describe it to patients is, well, it's like a guitar string and you're shortening the guitar string and you're going to get a higher pitch out of it. Complications that can occur, well, if the cords don't stay together and they don't form a mature scar, you're going to get scar tissue between the vibratory surfaces of the vocal cords, and that can give you dysphonia, whether it's a gravelly or breathy voice, or you're not going to get the pitch that you wanted. Even if you do manage to get that scar web, patients may not be happy with the pitch, whether it's too low or maybe even too high. And of course, shortness of breath. Anytime you're working on the voice box, it's a very sensitive part of the body. People are very cognizant of their breathing, and they can just perceive that change in a chronic fashion. Just wanted to touch on adjunct procedures as with our last talk. Adam's apple reduction or chondrolaryngoplasty and facial feminization procedures, which address how patients are identified visually. I never performed the two surgeries together. So, sorry, these two procedures can be done together, but voice feminization is always done in isolation because of the nature of the airway. Any additional swelling, extra time under anesthesia, that kind of stuff is just not indicated during a voice feminization surgery. We just want to focus on that. They can heal. They can do that first, or if they want to do a facial feminization, they can do that first, but not at the same time. Facial feminization procedures generally refer to a brow lift, making the eyes wider, forehead reduction, enlarging the orbital rims. Women have much larger and brighter eyes, and their brows sit higher on the rims. Rhinoplasty, cheek implants, mandible contouring, and of course, lip lift, as well as chondrolaryngoplasty. These are most common feminization procedures. I want to give an acknowledgement to Dr. Jeffrey Spiegel. He was my mentor in residency and the head of the facial plastic division at BU and the fellowship director. And so his main specialty is facial feminization. He's been doing it for decades. He's a pioneer in the field and very high volume. And, I've absorbed so much of my past training from so many people, but facial feminization is, all due to Dr. Spiegel and his work and his efforts to train us so fluently in it. So thanks, Dr. Spiegel. Some citations, the studies I used. And here's my contact. Email me, call me. I'm here for you guys. I want to hear from you. So look forward to working with all of you. Any questions?
Thank you so much. Yeah, any questions? Unmute yourselves.
I had one question. Hi, my name is Marin. I work at Stonewall. I'm curious, as a non-medical entity, but an entity that we make a lot of referrals to different medical providers for gender affirming services, what is the best way to connect people interested in voice feminization surgery to you? Is it this contact info? Is it through a third-party provider? How does your referrals work?
Well, we're actually changing our referral process. We're in that process right now where we don't need formal referrals. I don't know if that's actually switched over or not. And you can just call the office. There's a fax number, which unfortunately I don't have memorized and don't have on this form. But if you just call the office, which is that number listed,
Okay.
and tell them you want to make a referral to the office for this, they'll set it up. And so I don't think patients need to see a speech therapist first. Like, I have a lot of knowledge in this stuff and can kind of guide them through it, and we'll set them up with speech therapy. So I'm happy to be kind of the first person that they talk to. Almost always, I would say that patients have seen an endocrinologist first before meeting me, which is fantastic. I don't think hormone therapy gets patients to where they want to go when we're talking about going from a male voice to a female voice. It does work the other way around. So, it's one of those things that patients will discuss with their endocrinologist, that there's more room for improvement that they're looking for. And, I've had some referrals come from endocrine here, and that's great. But if you just want to send them over to me and I can talk to them, happy to do it.
Awesome. Thank you so much. I'm so
Okay.
grateful for your presentation.
Put our ENT fax in the chat too.
Yeah, so the ENT fax number is there in the chat. If you want to fax over a referral or just call, email me. I'm pretty easygoing. I can also help you out.
Thank you so much.
Sure thing.
Well, thank you, Dr. Hashemi, and to Dr. Sunil for your presentations. If you have any further questions, it looks like there's ways to contact them directly. And we're going to wrap up just because it's probably time for everybody else to go on to the next items on their day, on their calendar. So thanks again for joining, and Butte-Glenn Medical Society virtual grand rounds will continue soon.
Thank you.
Thank you. Bye.
Bye, everybody.
Thank you.
Oh, Dr. Really, Ron, about 40. Oh, Dr. I'm just going to say it out loud. We look for about 45 minutes with presentation and then Q&A. And Q&A really depends on the presentation. Sometimes there are none. Today seemed to be a little bit on more. And then we have new Enloe presentations that we're incorporating because they are our sponsor providing free CME. With you will have, they will be taking about 10 minutes to talk about their new urology program on May 27th.
Oh, okay. So it really is like 45 minutes then.
Yeah, so then a full hour, 12:15 to 1:15 is what I try to squish all together.
Mm-hmm.
But sometimes it goes over and people are more than happy to stay. But it's best to keep the whole thing within an hour just because everybody's busy. Yeah.
Yeah. No, I'm just trying to figure out how much. I apologize for the change in topic. The whole law changes have been wild recently. We went from it's going to be legal for everybody to do it to it's not. Then it just came back like what, like a week ago. So anyway, I will send you a title today. I was just mucking around with how much I could cover in a 45 to 50 minute period. So I will cover as much as I can, but I think my goal at this point is to cover the new laws, how you're able to prescribe Suboxone, the resources in the community, and then kind of a brief tutorial on how to do it for people that get kind of stuck in the situation of having somebody in need. So I just need to find a title that encompasses that, but I'm working on it actively. I will send it to you today.
Yeah, and thank goodness we put this down for May 27th. Imagine you had done it earlier in the year and then we had to redo it. So I think we're in good time.
Yeah, absolutely. So anyway, I will work on that, but thank you so much. Really appreciate it.
Yeah, thank you.
Have a great rest of your day.
You too.
Bye.
Bye-bye.